Hi, everybody. Thanks for allowing me to do this. I'm coming to you live from my patio here in Carmel, so that's the background here. Thanks, Brittany, and thanks for the opportunity to do this. That's my intro screen, and let's just launch in. The agenda tonight, we're going to go through just some basics of prostate cancer, basics of treatment options. Then we're going to drill down on specifically radiation therapy and then the SpaceOAR Hydrogel placement. And then we'll answer some questions and we have some next steps. This is being sponsored by Boston Scientific, and we do appreciate this. I do appreciate the opportunity to speak to y'all, and thanks Boston Scientific for hosting this. Just basic overview. So this is the basic anatomy of the prostate. And this is a side view. Of course, you have the rectum to the right of the screen. And then right in front of the rectum is the prostate, the bladder with the prostatic urethra running through the prostate, or the prostate surrounds the urethra, so to speak. The prostate is part of the male reproductive and urinary systems. It does provide fluid to the ejaculate, so it has a significant role in reproduction. It's usually about the size of a walnut, but we can see it bigger. It can go from a walnut all the way up to a grapefruit. So, and again, it supplies fluid that transports sperm during ejaculation. And I have lost, there we go. Just quickly, BPH, or benign prostatic hyperplasia, it's commonly known as an enlarged prostate. You can see the comparison there. On the left is the normal prostate, on the right is the enlarged prostate. As men age, the prostate grows in size and compresses against the urethra, or surrounds the urethra and compresses it, causing bothersome symptoms. It's important to know that BPH is not cancer. BPH exists with cancer in most cases. Having an enlarged prostate does not mean you're at higher risk of developing cancer. Most of the symptoms many of you have right now, whether you have cancer or not, is not due to the cancer, most likely. It's usually due to the enlarged prostate, unless the cancer is quite advanced. But weak urine flow, difficulty starting and stopping the stream, and increased PSA levels can happen even with BPH. Urgency and frequency and getting up at night are quite often common as well. So in terms of prostate cancer, it is the most common cancer among men after skin cancer. 5-year survival rates are 98% generally when men are diagnosed. So this is a different kind of cancer. It is typically slow growing, and even the more advanced, even the more aggressive type cancers that we'll talk about in a minute are typically slow growing. And at diagnosis, most men have a good 5-year survival rate. In 2022, around 268,500 new cases were diagnosed. Around 34,500 deaths occurred due to prostate cancer. The 5-year relative survival rate for localized cancer is greater than 99%. The 5-year relative survival rate for all stages combined is 98%. So should cause just a lot of, maybe perhaps some relief that this is not one of those cancers that's going to cause you harm within 5 years, in many cases within 10 years. About 1 in 8 men will be diagnosed with prostate cancer in his lifetime. Risk factors, of course, aging. Aging men can get prostate cancer. Chance of having prostate cancer rises rapidly after age 50. Over half the prostate cancer cases are found in men over 65. Genetics plays a huge role. There's a strong hereditary component. But most cancer occurs in men without a family history. But having a father, brother, a first-degree relative, we say, more than doubles your risk. Compared to white men in the U.S., Black men are 1.7 times more likely to be diagnosed with prostate cancer. Latino and Hispanic men are 21% less likely to receive treatment. So there's some race and ethnicity disparities here. There have been, in terms of behavior and lifestyle, some studies suggest chemical exposures. I'm not quite sure about the prostatitis and sexually transmitted disease issue. High-fat diets are one of the things that have been linked to as well. But smoking is not a big risk factor in prostate cancer. Most cancers these days are first found as a result of screening or early detection. Although that was a significant controversy about 10 years ago. I'll get back to that in a second. In general, if you look at the American Urologic Association guidelines and the National Cancer Care Network guidelines, around age 50 to 55, men ought to start being checked for prostate cancer screening with an exam and a PSA. That's for men with average risk of prostate cancer. It's interesting that many of our primary care colleagues are not doing rectal exams. And it's in their guidelines, interestingly enough. And if you talk to most urologists, we wholeheartedly disagree with that. We think men should still have rectal exams. So I would, for those of you who have not been diagnosed with cancer, I would all encourage you to talk to your primary care physician and ask them to do a rectal exam. If they don't want to do it, then come see your urologist. The reason for that is that 20% of cancers are diagnosed in men who have normal PSAs, and the only thing that is wrong with them is an abnormal exam. And those are the worst kind of cancers. The worst kind of cancers to have are the ones with low PSAs and a significant finding on exam. So for men at higher risk, African-American men or men with a family history, we recommend starting to be screened with PSA and exams around age 40 to 45. The most two common ways we screen again, or try to for early diagnosis, is PSA blood test. PSA molecule is actually an enzyme or a protein that's produced by the prostate. It's in the ejaculate, so it does have a role in male reproduction, but it also is secreted in the bloodstream. Most men with prostate cancer do have an elevated PSA, but just because your PSA is elevated does not mean you have cancer. Again, wholeheartedly recommend a digital rectal exam. So please ask your primary care physicians to do it. If the results of either of these are abnormal, we may end up going right to a biopsy. We may do an MRI or a transrectal ultrasound where we image the prostate. Actually, transrectal ultrasound is only done if we do a biopsy. So if we're concerned about finding cancer or findings on an X-ray that are concerning for cancer, we're going to go right to an MRI these days. And that's pretty much becoming standard of care. Genetic testing is really done after a diagnosis is made to try to ascertain what kind of risk other family members, especially sons and brothers, may have, what kind of risk they may have. A lot of times patients are diagnosed with prostate cancer during workup of other problems such as pain, difficulty voiding. A lot of times it's found when we do surgery for difficulty voiding, and we find it in the surgical specimen. Up to now, prostate biopsy is really the only way to confirm the presence and severity of the prostate cancer. We can do it transrectally or transperineally through the area between the anus and the scrotum. We take samples of the prostate using a thin hollow needle, and usually there's multiple samples taken. And the pathology report will tell us if cancer is found or not. When we do make a diagnosis, we try to stage and grade the cancer. So the stage is essentially how much cancer there is, the extent of your cancer. T&M staging means tumor, nodes, and metastasis. And again, that is measuring the extent of your tumor. The Gleason score is the grading of the tumor, and the grade of tumors is defined as an attempt by looking under the microscope to assess or estimate the biologic activity of a cancer. So most cancers that we have are graded in one way, shape, or form. In prostate cancer, it's called the Gleason score because a man named Gleason came up with this back in the 70s. Other things we look at are PSAs, perhaps some imaging such as bone scans or CAT scans, and now PSMA PET scans are done. Again, a clinical exam is done. We may do some genomic testing, try to assess the volume of the tumor, and then we also do some other laboratories in some cases, not all. This is the staging system. Again, the tumor nodes metastasis. When we talk to you guys, a lot of times we'll say this is stage 1, 2, 3, or 4. Stage 1 or 2 means it's confined to the prostate. Stage 4 means it's beyond the prostate. The Gleason score is important. So this is the slide depicting the Gleason score. We try to risk stratify every cancer. So prostate cancer is commonly graded by the Gleason score, which assesses abnormal tumor cell growth. My professor, where I trained, drilled this into us that is an attempt by looking under the microscope to assess the biologic activity of a tumor. So we try to risk stratify patients based on the Gleason score. So if the Gleason score is less than or equal to 6, this is graded on a 1 to 5 scale. And if it's a 3+3, Gleason score 3+3, it could be a very low risk. Very low risk cancers are cancers with less than or equal to 3 cores and less than or equal to 50% of any core. You can have favorable intermediate disease, which is a 3+4. Unfavorable intermediate disease is the 4+3, and then high risk is anything above that. High risk is Gleason 8. Very high risk has a score of 9 or 10. So that's important information in addition to the staging, and that helps us dictate what we're going to recommend. And here we go into treatment options. Okay. So these are the 3 most common treatment options. There are other treatment options: hormone therapy, chemotherapy. That's for more advanced disease. We may do hormone therapy in conjunction with radiation therapy if the cancer is high grade or high risk or unfavorable intermediate risk. Cryotherapy is a freezing technique, which is done in some cases. High intensity focused ultrasound is a heating technique that can be done in some cases. These are both focal therapies. So if you have a low volume of cancer on one side, we can target that cancer this way and just treat the cancer and not have to treat the whole gland. We don't do this a whole lot, but in selected cases, it is something that can be done. Immunotherapy is for more advanced disease, and targeted therapy is what I just talked about with the cryo and the HIFU. But most commonly, we do active surveillance, surgery, or radiation therapy. Active surveillance is a way of monitoring cancers that are low risk or very low risk, and cancers that will not harm a patient in the short term and possibly even in the long term. It's done to either avoid completely or at least delay treatment. And one of the reasons why would we do this? Well, Gleason 6 cancers are the most common type of cancers we monitor like this. It's overkill in many cases to treat those kind of tumors, and we want to avoid side effects, especially incontinence and sexual dysfunction. We do PSA testing every 6 months. We do DREs I do DREs every 6 months. And in a 6 to 18 month period of time, I'll do another MRI and a biopsy. I would change the slide a little bit. The only potential side effect of active surveillance is anxiety and worry. So there's no advancing of your cancer, but we're going to find that because we're testing you and monitoring you so actively. So the key word in active surveillance is active. There's no anesthesia, obviously. There's no hospital stay, and it's not invasive, certainly. Surgery, typically, it's called a radical prostatectomy. We can do that with an open technique where we make an incision from the umbilicus down to the pubis. Nowadays, 95% of these are done robotically with a laparoscopic technique, usually robotic assisted. There is general anesthesia. There is generally a hospital stay. Yes, it's invasive. Potential side effects include incontinence, sexual dysfunction, and certainly loss of fertility, because we're removing everything that provides fluid to the ejaculate. There are other side effects, obviously, of surgery, such as bleeding, infection, bowel injury, and hookup complications like leakage and stricture formation. Generally, I think it's important to know that we, as surgeons, generally only pursue curative surgical therapy in men in whom we're confident have a 10 to 15 year life expectancy. Okay. So if you're older, in your 70s, certainly in your early 70s, we really think twice about doing surgery unless it's a very aggressive high-risk cancer. And if you're in your 70s, then we need to make sure you're pretty darn healthy and that you have a good chance of living well into your 80s and 90s. Otherwise, we've got other good options. Okay. Radiation therapy got primarily focused on external beam radiation therapy. There are other forms of radiation, such as SBRT or stereotactic therapy, brachytherapy with seeds, and proton therapy. And if you have questions, I can answer that. But in general, we're doing IMRT in our group, or EB, external beam. It's also called IMRT. Basically, high energy rays or particles kill the cancer cells. Radiation is delivered from a machine outside the body. It's focused and targeted right onto the prostate. Treatments are generally outpatient. They only take a few minutes once you're up and going. There's no anesthesia, there's no hospital stay, and it's not invasive. Potential side effects are urinary, not just incontinence, but bleeding and some bladder irritation. You can get sexual dysfunction eventually. May not happen as soon as it happens with surgery. And you can get bowel dysfunction, such as diarrhea, blood in your stool, and some rectal leakage at worst. Remote risk of fistulization or abnormal openings between the bladder or prostate and the rectum. I talked a little bit about brachytherapy. There's not a whole lot of brachytherapy being done around anymore, mainly because in my opinion, in my experience, the voiding side effects were a lot higher with brachytherapy. Most seed implants now have to be done with external beam anyway. Most protocols call for a short course of external beam therapy in addition to seed implants. And in my experience, it was there was just a lot of complications. And with the advances in external beam therapy, the side effects are a lot lower. So at least in our practice at Urology of Indiana, we're doing really no brachytherapy now. I talked about other options in radiation therapy. 3D conformal, IMRT and IGRT are all basically the same thing. Stereotactic body radiation is short courses, usually just 5 courses, really targeted onto the prostate. That is available. Honestly, I don't think it's as, I think if you're going to have that, it ought to be done for very low volume, relatively low grade disease, if that's going to be considered. Proton therapy, all I can tell you is that the linear accelerator at IU shut down because there was nobody using it. If you talk to the radiation oncologists here in town, they will say it's no better and no safer than standard radiation therapy. I already talked about brachytherapy a little bit. So want to talk a little bit about how can we make radiation safer to the rectum, especially, because that's one of the big things that happens with radiation therapy. Remember that anatomic slide, the rectum was sitting perilously close to the prostate. So how can we make things safer? Okay. The prostate sits very close to other organs, such as the bladder here and the rectum. Possible side effects include urinary and sexual bowel dysfunction, bleeding, and things like that. The rectum is an organ at risk of receiving unintentional radiation, kind of collateral damage, we say. Rectal toxicity side effects can include diarrhea, pain, bleeding, frequency, and urgency. In one study on radiation effects to the GI and GU, let's get into rectal spacing. That's what we're talking about, the SpaceOAR. So what we're doing with the SpaceOAR is we're basically creating a larger space between the rectum and the prostate. 551 patients in this one study, 551 patients underwent radiation therapy for prostate cancer. 269 of them received the SpaceOAR Hydrogel as a pre-treatment. And you can see that the use of a rectal spacer was significantly associated with reduced late GI toxicity or bowel toxicity and lower odds of developing late GU toxicity. You can see here that in the blue were the SpaceOAR patients, in the gray were no SpaceOAR patients. So you can see for yourself kind of the difference in toxicity. What is SpaceOAR? It is a absorbable hydrogel that temporarily creates space between the prostate and the rectum, designed to reduce radiation dose to the rectum to help minimize the side effects of radiation therapy. It creates about a 1.3, about 1.5 centimeters space between the prostate and the rectum. You can see that there. It's a soft gel material, mostly made of water and polyethylene glycol, which is used in other medical implants. That's important to know. It's a brief outpatient procedure. We generally do it under local anesthesia in the office, or it can be done under general anesthesia or with some sedation. It stays in place for about 3 months, and after about 6 months, it's naturally absorbed, and it basically leaves the body through your urine. So it's clinically proven. More space can mean a better quality of life. There's fewer bowel complications. 3 years following treatments, patients experience 75% less grade 1 rectal toxicity, for instance, urgency, loose stools, and frequency. There are fewer urinary complications, interestingly enough. Use of SpaceOAR reduced the likelihood of decline in urinary quality of life by 60%. And also there was fewer sexual complications. 67% of patients, SpaceOAR patients who were potent at baseline had erections sufficient for sex at 3 years. So this has been used a lot around the country. More than 500 centers around the world purchase SpaceOAR Hydrogel with 220,000 to date, 220,000 patients to date, and it is growing. Certainly that's the case in our group. So in summary, radiation therapy can be extremely effective in treating prostate cancer. But as with any procedure, there are potential side effects. Prostate's very close. Due to that proximity, prostate radiation therapy can unintentionally cause damage to the rectum, which can lead to issues with bowel function. This SpaceOAR Hydrogel, is designed to temporarily create space between the prostate and the rectum, reducing the radiation dose delivered to the rectum during prostate radiation therapy, which may lessen damage to the rectum. Next steps, know your risk level if you've already been diagnosed. If you've not, talk to your doctor about screening, learn more about options. There are resources, American Cancer Society, Zero Prostate is an organization committed to reducing the rate of prostate cancer and zero deaths, et cetera. And there's a prostate health education network. So these websites are here. You want to learn more about SpaceOAR, you can text SpaceOAR to this number to text. You can speak to a patient coordinator, or you can visit spaceoar.com. Thank you for your attention, and I'll take any questions.